Good evening. Good evening. Let's try this one more time. Good evening. So it's my honor to welcome you to the 2026 Mandel and Child Welfare Leadership Fellows Capstone presentation. And of course you can guess who's sitting in the back here. These are our fellows who are eager to present and show you what they've been up to over the past couple of years. My name is Dexter Vorzan, and I have the privilege of leading this incredible institution since January 2022. So whether you're joining us in person or on live stream, we are grateful for your presence. Tonight is truly a celebration of inquiry, grit, and the deep commitment of our students who are committed to what communities they serve. This is an annual event that we look forward to every year. This year is especially significant because we celebrate Case Western Reserve University's bicentennial. And as we honor 2 centuries of achievement, tonight's fellows represent the next generation of change. Now, none of this would be possible without the visionary and generous support of the Mandel brothers and the Jack Joseph and Morton Mandel Foundation. Their ongoing funding supports this program. However, it is the deep commitment of our volunteers that provide the practice wisdom and support that guides our fellows. Now, I was asking Dr. Hussey, how many mentors do we have? So I want the mentors to stand. We want to give them a special recognition. The mentors, please. Come on, Paula, stand up. All the mentors, come on, come on. And several of our mentors have not 1, have 2, but 3 mentees. So we want to thank you so much for your time, commitment, and for pouring into these incredible students. Now I'm going to introduce you to the man who makes all things happen, Dr. David Hussey. He's been director of this program for many years, and he was just telling me, Dexter, listen, we have one of our 4th cohort members who are coming back, and they're actually mentors in the program. So this is a real full circle moment. So please join me in welcoming Dr. Hussey, and he'll tell us more about the program and our incredible fellows.
Thank you very much, Dean Vorzan. I'm delighted to introduce this year's Capstone presentations. This semester, and the fellows have been working extremely hard to prepare for the Capstone presentations. This year we have 8 fellows, 7 Mandel Leadership Fellows, and 1 Child Welfare Leadership Fellow. As you listen tonight, you'll discover these important themes that exemplify the field of social work. Accessibility, the importance of language and cognition, and language accessibility, especially for immigrant populations. The power of integrated care and integrated treatment models, both for vets and for individuals who have intellectual and developmental disabilities and co-occurring mental health issues. The growing awareness of the need for grief and loss services for our children. How novel and exciting drama and art therapies can be employed in social work practice. And much of the Capstone focus, aside from evidence-based, has historically been on practice, innovations, and advancements. You'll note the range of populations, the range of problems, the range of settings, and the range of interventions. Methodologically, you'll see 2 primary methods used for the Capstone. Very sort of rigorous literature reviews and expert interviews. And I was extremely pleased to see the level of some of the experts that our fellows interviewed for their Capstone projects. There will be implications for both practice as well as for us as educators. implications for social work training. Process-wise, there will be 8 crisp 7-minute presentations. Due to time considerations, there's no formal question and answer period for the stream portion of the program. However, you could make comments in the chat, and you could obtain the emails of the fellows if you have questions or you want to send them a message. They probably won't respond tonight, but they will respond in the following days. Emma, our last presenter, will conclude the remote part of the program and invite us to transition to the traditional poster session for those of you who are with us in person. Once again, thanks so much for joining us. And without further ado, I introduce our first speaker, Mr. Zachary Colton.
Can you hear me? Cool. So good evening, everyone. As you can see, my poster is titled Not Just Another Group, Provider Perspectives on VA Residential Substance Use Treatment Program for Men. So this capstone focuses on a men's residential substance use disorder treatment program within the Louis Stokes VA Cleveland Medical Center. Substance use disorders are a major concern among veterans, many who face complex challenges such as trauma, mental health concerns, and the stress of transitioning back into civilian life. Because of this, residential treatment programs within the VA can play an important role by providing intensive, structured, and interdisciplinary care. These programs are designed to do more than simply help someone stop using substances, though. They aim to support the whole person. In the program I focused on, treatment includes individual and group psychotherapy, which primarily is CBT, cognitive behavioral therapy, medication management, case management, discharge planning, and aftercare coordination. Although prior research has shown that residential substance use disorder treatment programs can be very effective, much of the literature focuses on treatment outcomes. There has been comparatively less attention given to the implementation side of care, especially how providers understand what is working well and what barriers are experienced, and then how different program components are interacting in practice. The purpose of this capstone was to propose a qualitative process evaluation of the men's residential substance use program. This evaluation centers around provider perspectives. Specifically, it explores perceived strengths of the program and challenges to care delivery. This project uses a qualitative process evaluation design with semi-structured interviews. Veterans in this program are usually in residential for around 4 to 6 weeks. And while it is a men's only program, the VA also has a women's only substance use program. Data collection included both a literature review and individual provider interviews. Again, the interviews focused on program strengths and barriers. And interviewees included two social workers and 2 clinical psychologists who work within the men's residential program. If you look at the top middle, you can see the theory of change. So this helps explain kind of what is expected as a veteran goes throughout the treatment program. So they enter the program with a substance use and potentially another mental health disorder. They then receive interdisciplinary residential treatment. Through this structure, veterans ideally develop improved coping skills and stronger engagement in treatment. Those gains are expected to reduce substance use risk, improve stability, and ultimately support sustained recovery and improved overall well-being. Turning to the findings, the literature review, as I mentioned at the beginning, showed that while there is a lot of support for the use of treatments in residential, such as cognitive behavioral therapy, there's much less attention paid to what it actually looks like when all of these different components that you see in the middle are used together. So in the qualitative findings, one of the strongest themes that was identified was interdisciplinary collaboration. One of the social workers stated, "I think that we definitely work well as a team. We seem to have good wraparound service for them." This quote highlights that providers view the team-based and wraparound nature of the program as one of its core strengths. Another major theme was holistic care. Providers emphasize that treatment is not solely focused on sobriety. It addresses mental health needs, medical concerns, housing, spirituality, and social support. Providers also noted that residential setting itself helps veterans begin building trust, community, and social support. As one social worker explained, veterans begin realizing that they want to rely more on healthier supports and instead of those unhealthy relationships that they had prior to entering treatment. At the same time, there were several barriers or areas for improvement that were identified. One challenge involved case management demands, which fall heavily onto the therapists. A psychologist noted that because veterans may not have a dedicated VA case manager, therapists often end up doing the substantial case management work. This is especially a concern when it takes up time for what should be individual psychotherapy. Providers also raised concerns about screening and admission processes, particularly since those decisions are made by people who are not located in Cleveland and they're at a central screening agency that does not know what the residential program looks like. This can lead to referrals not being the best fit for the program. There were additional concerns that included inconsistency in non-core programming and outside supports. So overall, these findings suggest that the program's greatest strengths lie in its interdisciplinary collaboration, structured treatment environment, and holistic approach to recovery. However, providers also identified system-level barriers that can weaken treatment effectiveness, especially when clinical time is pulled towards administrative demands or when screening processes do not consistently align with the program's needs. Based on these findings, potential improvements would include strengthening the screening and referral process to improve fit and clinical information gathering, increasing case management and housing coordination to reduce the burden on therapists to perform these duties, and improving communication with outside services. Important limitations for this project, this only reflects one VA residential program in Cleveland, so it's not generalizable to VA communities across the country. This also did not include any veteran interviews, which limits understanding of the lived treatment experience. Some future directions would include incorporating veteran perspectives and, again, looking at VAs across the country and seeing if different practices are implemented in different ways. So overall, this project suggests that residential substance use disorder treatment at the VA is most powerful when it is understood as more than just a set of services or groups. Its value appears to come from how interdisciplinary relationships, holistic care, structure, and peer support work together to promote recovery. Thank you very much. And next, I'd like to introduce Elizabeth Gilreath.
Good evening. My name is Elizabeth Gilreath, and my capstone is Space to Speak, exploring the impact of language accessibility for limited English proficiency individuals. To begin, it's important for us to understand why language accessibility matters. The United States is home to people who speak hundreds of different languages. In fact, it is estimated that there are about 16.3 million Spanish-speaking households in the US, and that 3.1 million of those are classified as limited English-speaking households. Recent data shows that approximately 60 million adults in the US experience a mental, behavioral, or emotional disorder each year. Of that number, about 35% of Hispanic or Latinx adults with mental illness receive treatment each year, compared to the US average of around 46%. This showcases the disparity that individuals who speak another language may experience. As these numbers continue to grow, the need for language accessibility and mental health services grows with it. Despite this need, mental health service providers and agencies approach language accessibility in very different ways. The main options for the delivery of language accessible services, as you can see in the top figure, are virtual interpreters, which could now look like AI, or a virtual interpreter who is interpreting live over the phone or over the internet. In-person interpreters who are hired by the agency directly or through a third party, ad hoc or third-party interpreters who may be a front desk worker or somebody else in the agency who happens to speak the language, or a family member who came with a client, and multilingual clinicians who are able to provide the therapy directly in the language that the client speaks. Among the different methods, there can be variations in training, certification, and the quality of services provided by interpreters and clinicians. There is not a standard exam that is used across all clinical settings for clinicians to take to evaluate their clinical vocabulary or language proficiency, nor is there a certification process or standards that are consistent for all interpreters. Different agencies may enact their own individual policies or none at all. The lack of standardization and consistent accessible practices can leave clients to pay the cost. This lack of accessibility can be a significant hurdle to clients not receiving care. One expert that I talked to highlighted that some clients call 2 or 3 agencies before they find a multilingual clinician. And this made us wonder how many people give up and decide they don't need therapy at all after facing challenges finding a clinician who can speak their language. It is important to note that language accessibility is not limited to only affecting the Spanish-speaking population in the United States. Nevertheless, this is the population that I chose to focus on for my capstone. In order to examine how different language accessibility methods can impact treatment, I conducted a literature review and expert interviews. I conducted a literature reviews using the following terms: language, accessibility, therapy services, mental health, interpret, and Spanish. And for the expert interviews, I spoke with 3 experts within the field of Spanish-speaking mental health services, including 2 psychologists and a social worker. I asked each of the interviewees 5 main questions about their relation to the field, their experiences with language accessibility, challenges they have faced, and what they have seen work well, and recommendations that they have for future directions. The literature review and expert interviews yielded some major findings. First, the literature review showed that limited English proficiency is associated with a lower utilization of mental health services. Secondly, interpreting can add additional complexities to counseling, such as a different dynamic between having 2 people in the room to now having 3, so clinicians and interpreters navigating a dyad versus a triad. Additionally, there's a time element. When interpreters were involved in a session, the sessions tend to take a lot longer, and the amount of content that can be covered is decreased. There can also be different cultural backgrounds between the client and the interpreter. Sometimes it can be helpful, and other times it can be a mismatch and lead to increased stigma that the client experiences. The lack of established qualifications and certification standards for interpreters can make it difficult to define and assess an interpreter's role. Despite these challenges, the literature reviews showed that trained interpreters can significantly increase access to mental health care. And really importantly, the literature review showed that both interpreters and multilingual clinicians can facilitate the creation of strong therapeutic alliances between clients and clinicians. Within the expert interviews, it was revealed that there is a need for more Spanish-speaking clinicians in the field, and that there is a preference for in-person bilingual clinicians over interpreters. There also can be significant financial limitations and government changes that can impact accessibility to services. But it's important to note that language accessibility goes beyond interpreting. It includes screening tools, assessment measures, signage, processing for scheduling, and community resources being available in a language. One expert highlighted that there's a need for cultural awareness. She said not only people who can speak the language, but people who know how different conditions are likely to show up in different populations. It's also important that interpreters receive training related to mental health vocabulary and process and things like trauma-informed care. Another expert highlighted that the lack of institutional support for language services is a challenge, and she said that she would like to see graduate programs understand this as an important piece of training and that students are already providing services to Spanish-speaking or monolingual families without the proper training. So we could be having improved services if we offer the training. Based on these findings, I recommend that a multi-level approach be taken to address these needs. At the micro level, I propose that there be standardized mental health training, clear defining of roles, and pre- and post-session meetings as things that could be helpful to increase the effectiveness of interpreters. Increased tools for evaluating language needs would also be helpful. Additionally, decreased caseload, increased pay for multilingual providers, and supervision available in another language as well as note processes available in another language could also be helpful to mitigate the increased mental and workload that multilingual clinicians experience. And increased visibility of language materials could go a long way as well. At the macro level, institutional level advocacy for funding and resources, as well as increased workforce through the use of bilingual community members who could serve as community health workers, and incorporation of language-specific training into graduate programs could help equip professionals to meet the need. In summary, interpreters can foster client-clinician alliance and help mitigate disparities. When available, multilingual clinicians are preferred by clients and uniquely positioned to address both cultural and lingual needs. Financial and funding challenges can increase the difficulty of navigating systems, and current practices are not sufficient. The need for multilingual clinicians will not go away, so there are opportunities to address the need by equipping clinicians and organizations to support limited English proficiency communities. As Dr. Martinez mentioned, multilingual people get subpar treatment because the language and cultural resources are not there. With a multi-level approach, there can be increased visibility, advocacy, training, and financial support. It is possible for limited English proficiency individuals to receive more equitable mental health care. Thank you, and it is my pleasure to introduce Andrea Gutierrez de la Fuente.
Hi, everyone. Good evening. Thank you for being here. So my capstone is titled Stepping into Yourself, Evaluating Drama Therapy's Impact on Youth with Adversity. So to give you a little bit of background, before I came to grad school, I was working as a teaching artist and site coordinator for a local Cleveland Public Theater, a local theater here in Cleveland. And I was working with CMHA youth, so youth living in CMHA communities, public housing, and basically creating shows from scratch. And it was everything based on what they wanted to do. So I noticed that while I was trained in trauma-informed care and healing-centered engagement, there were a lot of skills that I needed to be in communities where so many systems were impacting this room, right? So I also noticed in my work with engaging young folks with theater that this was really powerful, and it was making strides in social emotional learning and community building, in identity development, but I understood that I needed a lot more skills, so this is why I'm here. So adverse childhood experiences, or ACEs, are potentially traumatic experiences under the age of 18 that happened before the age of 18. So that can include witnessing partner violence, substance use in the home, being physically or sexually assaulted. And these things can cause something called toxic stress. And we understand from the research that this mostly happens to children and people who are both racially and economically disenfranchised in the United States. For example, as you can see here, 1 in 5 adolescents across 16 states had 4 or more ACEs. And what we also know about having 4 or more ACEs is that that really increases your likelihood to experience not only a mental health diagnosis, but also a physical health diagnosis. And we also know from the research that trauma does not only impact our brains and our cognitions, but it also impacts our bodies. A lot of the ACEs have to do with our bodies. So trauma-informed cognitive behavioral therapy or narrative therapy, which are really highly evidence-based and really have really great outcomes when intervening with children with ACEs, they mostly focus on the cognitions of people and not so much the somatic elements. So drama therapy offers a really, really great opportunity to engage a person both cognitively and somatically through creativity, spontaneity, and play. So I had the opportunity to review the 3 systematic reviews that are out there on drama therapy with children. Yes, it's not a lot of data, but I also had some really incredible interviews with some drama therapists, as well as the director of education at Cleveland Public Theater. So I know we're probably all asking, what is drama therapy, right? So I have some core components right here, but according to the North American Drama Therapy Association, it's the intentional use of drama and or theater processes to achieve therapeutic goals. So what that can look like is doing mask work, so having a mask on and being able to tell your story, but also creating distance between yourself and the story, because it doesn't have to necessarily be you up there. It can look like improvisation and having to think on your feet. It can also look like taking on a character who has really different experiences than you and creating them with the use of props and costumes and different physicality. So I also want to say a quote that Britt Cheetah, who's an artist in Oregon, who really talks about the importance of play. She says, play is the opposite of survival. So when we think about trauma and when we think about chronic stress, we understand that when we are under chronic stress, we're triggered by events that aren't necessarily dangerous, and we're living in a state of fight or flight. You can't really do that when you're improvising. You can't really do that when you're playing with other people. So it provides an opportunity to, even for a moment, to have to be present and play with others, which has been done for as long as humans have been around. So my theory of change with drama therapy is that when children experience adverse events, it not only impacts their cognitions, but also their bodies. So this adversity can really impact normal development. If we think about a child who's having to call for help if their parent has overdosed or has experienced some kind of assault, these are not what we would expect normal developmental steps to be. Kids might not even have the language to express what has happened to them. Drama therapy offers a way to intervene with these issues through a way that sees them as a whole person and not just cognitively, but also somatically. Therefore, giving the children not just cognitive tools, but all kinds of different tools to live healthier lives. So the key findings are there's a lack of rigorous studies. So in many cases, a lot of these are case studies, not a lot of randomized control trials. There's also a lot of lack of control groups in these studies. It's very clear that drama therapy relies on spontaneity and freedom, which is very strength-based because you're giving the autonomy back to the children to tell the story in the way that they want to tell the story. And I also did find a manualized version that just got published last year. This is for adults with severe mental illness, but it's really great that there is finally a manualized version of drama therapy. Some key themes from my interviews were that fostering creativity and expression was really at the core of drama therapy. Usually these clinicians who are drama therapy have both a background in theater and in psychotherapy. And I want to say a quote by Dr. Wood, which is highlighted here on my poster, is, "What can't be put into words to be expressed." And like I mentioned, we've been doing this for hundreds and hundreds and hundreds of years already. So some implications are, as I've mentioned, small sample sizes. There's not a lot of rigorous studies done for drama therapy on children. And the fact that drama mirrors humanity and kind of life, it's a lot harder to synthesize and to study. So for future directions, in order to obtain that robustness that we're looking for, we must create a manual for children. And we already have an example created for adults. So I advocate for this manual to be implemented at school, specifically for youth who have ACEs and would not otherwise get treatment, as we understand that ACEs are more likely to happen with children who are both racially and economically disenfranchised. So to leave you off, this is really pertinent to social work because the very nature of our work is to understand how systems impact our clients, but it's also really important that we understand the systems that are our clients as well. And I'll leave you with a quote that Melissa Crum said, Director of Education at Cleveland Public Theater. She said, "When you're not utilizing the entire essence of your being, you're missing a part of yourself." So I implore everyone to stay up to date on drama therapy and advocate for further research to really uphold our social work values and everything that they are. Thank you, and with that, I will introduce Daniela Gutierrez Carrera.
Hi, everyone, and thank you for being here. The title of my presentation is Language and Cognition. What does it mean for narrative approaches with multilingual clients? So for some context, I have chosen this topic due to my own experiences as a multilingual mental health practitioner and my experiences working with multilingual client populations during my fieldwork here at CASE. It is through these experiences that I was able to witness the powerful role of language in session, as well as the importance of exploring how trauma is talked about in session and the role that language plays in talking about these experiences. The number of multilingual people in the US has risen rapidly from being every 1 in 10 people in 1980 to about 1 in 5 as of 2019. As this number continues to rise, so does their needs to access culturally competent and equitable services from direct practitioners in our field. To understand how we as clinicians can address and devise creative solutions to meet these needs, I've chosen to focus on the role of language in the therapeutic environment, specifically through the lens of 2 linguistic theories, linguistic relativity and linguistic oppression. Linguistic relativity can be applied to this population and how the differences in languages used for narration may impact both the client's and therapist's perception, expression, and interpretation of events. Linguistic oppression builds upon this idea through a systemic lens of language and power. Additionally, I've chosen to focus on the proposed integration of these theories into practice with this population using narrative therapy interventions, which involves using linguistic and cognitive processes to help clients tell their story and feel empowered in reauthoring the meaning and making of their stories. The theory of change for narrative therapy hypothesizes that engaging in these storytelling and reauthoring practices can allow clients the chance to reframe unhelpful thinking patterns and self-concepts, regain a sense of control, express their stories authentically, and build insights that instill lasting hope and change. This is achieved through 3 major techniques, which are listed here above. The first is externalizing or viewing the problem as separate from the person. The second is unique outcomes, which is recognizing when there was exceptions to the problem. And the third is renaming, which refers to reframing what the problem is or means within the greater context. To explore the integration of linguistic theories into narrative therapy interventions with this population, I've decided to conduct a thorough literature review of the existing research. During this review, I found 2 major themes regarding language and its role in the therapeutic setting. The first is in the various functions of using a primary versus secondary language in therapy. Research shows that using a primary language involves higher emotional intensity when recalling memories, complex affective processes in the brain, and our ability to remember sensory experiences, and greater use of perceptual processes in the brain, including our perceptions of time and space. Contrastingly, research also shows that using a secondary language may create more emotional distance between a person and their memories, and may require more effort to verbalize. Additionally, the use of strategic code switching may be used to protect oneself from traumatic memories. One quote from an existing review states, "The choice of therapy language is not a neutral element of the therapeutic setting, but may actively shape how clients engage with emotional materials and perceive therapeutic safety." Another area of importance found in this review is the complex dynamics between the therapeutic relationship, power, and positionality. Many multilingual and multicultural communities in the US face systemic disempowerment and devaluation, including with how they experience the impact of language assimilation and the development of protective code switching behaviors. This may impact rapport if a client feels linguistically or culturally misunderstood, and could lead to countertransference or transference issues based on language use and positionality that impact the trust and identification between a client and their therapist. Based on these findings, I propose increasing our knowledge base of linguistic theories and integrating these into our clinical practice with clients. This could be explored through clinician training aimed at increasing awareness, continued research of language functions in therapeutic settings, expanded collaboration across fields, including with cognitive sciences, psycholinguistics, and speech-language pathology fields, and implementing considerations of language, power, and positionality as part of anti-oppressive, systemic, and intersectionality frameworks. This does not come without limitations, as narrative therapy with multilingual communities is an under-researched topic currently, with little information to be found on outcome with this specific population. Research on language and cognition is also mostly found in other fields of study, and proposals found for clinical applications are fairly recent. Lastly, our current political climate exacerbates language injustice and oppression, creating a greater need for language empowerment within these communities. So what does it mean for the future of our practice in social work? Strengthening clinician awareness and incorporating linguistic research into practice may help bridge some of the gaps that multilingual populations face in accessing quality, dignified, and just care. I'd like to end with a quote that resonated with me on this topic that states, "The research suggests that the meaning a client gives to the language used in therapy will determine whether they feel empowered and accepted or alienated and disconnected. This meaning can be co-constructed within an attuned therapeutic relationship that attempts to go beyond the linguistic level to reach the human connectedness underlying culture." Thank you, and it is my pleasure to present our next speaker and peer, Barbara Owens.
Good evening. I am Barbara Owens, and I am a Child Welfare Fellow. My goal this evening is examining the question, among children and adolescents navigating prolonged grief disorder, does cognitive behavioral therapy compared to mindfulness lead to a greater reduction in emotional distress? I am presenting on prolonged grief disorder, or PGD, and exploring the evidence base for treatment in children and adolescents. Prolonged grief disorder occurs when a child and adolescent experiences intense, persistent grief that does not improve over time and begins to interfere with their daily functioning. While grief is a normal and necessary response to loss, PGD reflects a situation where a young person feels stuck in their grief, typically lasting at least 6 months. Research suggests that approximately 5 to 10% of youth develop prolonged grief disorder following a significant loss. The children may experience ongoing longing, difficulty accepting the loss, emotional distress, and challenging reconnecting with their everyday lives. The focus of this presentation is to explore effective evidence-based treatments with particular attention to cognitive behavioral therapy, or CBT, and how it compares to other approaches like mindfulness-based interventions. Grief in children often presents differently than in adults. Instead of expressing sadness directly, children may show behavioral changes, withdrawal, academic difficulties, or even physical symptoms like headaches and stomach aches. One of the biggest challenges is prolonged grief disorder is under-recognized, especially in schools and child welfare settings. Symptoms can easily be misinterpreted as, oh, they have anxiety, or they're depressed, or behavioral problems. Research indicates that 10 to 25% of bereaved children experience significant grief-related difficulties. Without appropriate support, these challenges could persist and impact long-term emotional and developmental outcomes. This highlights the importance of identifying targeted, developmentally approached interventions. That addresses both emotional and cognitive aspects of grief. To better understand effective treatment approaches, I conducted a review of current literature and incorporated expert interviews with professionals who work directly with grieving children. These included licensed clinical social workers, school-based practitioners, and grief specialists from organizations such as Beechbrook, Cornerstone of Hope, Cleveland Public School District, and Cleveland Clinic. My goal was to integrate research-based evidence and real-world clinical experience. Also, I identified 5 highly quality research studies from 2020 to 2026. I prioritized them using the hierarchy of study evidence by their ability to minimize biases and to determine causality, like systematic reviews, meta-analysis, and randomized controlled trials. Across both sources, a clear pattern emerged. While multiple approaches can support grieving children, structured skills-based interventions, particularly CBT, consistently show the strongest outcomes to prolonged grief disorder. So what does CBT actually look like in practice for a child experiencing prolonged grief disorder? I invite you to see my board after we are done so you can hear the portion that a therapist would offer. CBT focuses on identifying and challenging maladaptive thought patterns that keep children stuck in their grief. For example, a child might believe, it's my fault they died because I didn't say goodbye. Another common pattern is catastrophic thinking, such as, I'll never be happy again. Or emotional reasoning that sounds like, if I stop feeling sad, it means I'm forgetting them. Finally, children engage in avoidance, such as refusing to talk about the person who died or avoiding reminders altogether. CBT addresses this through gradual exposure, helping a child safely approach these thoughts and memories in a supportive way, which reduces distress over time. Overall, CBT does not aim to eliminate grief. Instead, it helps children process their loss, develop coping skills, and move forward in a healthy, meaningful way. The findings from both the literature and expert interviews consistently show CBT leads to a stronger outcome and mindfulness-based approaches when treating prolonged grief. Its structured, goal-oriented nature helps children actively address the thought patterns and maintaining their distress. Mindfulness-based interventions can still be beneficial for emotional regulation, but they may not fully address the cognitive distortion associated with PGD. Additionally, experts emphasize that the importance of early identification and intervention, particularly in school settings where children were most accessible. The findings have several important implications for practice. First, there's a clear need to increase awareness for prolonged grief disorder, especially among educators, social workers, and child professionals. Second, it is critical to expand access to evidence-based interventions like CBT, particularly in schools and community-based programs. And finally, supporting grieving children requires collaboration between mental health professionals, schools, families, to ensure consistent and effective care. In conclusion, while grief is not a natural part of life, prolonged grief disorder requires intentional, structured support. As a master classroom teacher and a soon-to-be social worker, I am advocating for more research, increasing awareness, and expanding access to effective treatments like CBT. We can help children not only cope with loss, but also continue to grow and thrive. Thank you for your time. I'd now like to introduce my colleague, Emily Reed.
Good evening. My capstone is Barriers to Care, Pathways to Change, Optimizing Mental Health Treatment Models for Individuals with Developmental Disabilities. The siloing of developmental disability services and mental health services makes it challenging for individuals with co-occurring conditions to receive high-quality mental health care. Many individuals with developmental disabilities, or DDs, find that they don't fit into either system. When they seek mental health treatment, they are often redirected back to DD-specific services, but those services may lack the capacity or training to address complex mental health needs. As a result, individuals are frequently bounced between systems with limited coordination. This fragmentation creates significant barriers to care, including issues of accessibility, availability, and acceptability. Even when services exist, they may not be appropriately adapted, and long wait lists further delay treatment. At the same time, many providers report not feeling competent enough to work with this population due to limited training, which contributes to inadequate or unequal care. This project explores how we can better support this population by identifying and leveraging existing, emerging, and evidence-based psychotherapy practices. Overall, the findings suggest that we can improve mental health care and outcomes for individuals with DDs by adapting and refining different approaches, making them both more effective and more accessible for clinicians and organizations to implement. Historically, care for individuals with DDs was rooted in institutionalization, medication, and behavioral compliance. There was also a misconception that these individuals did not experience mental health conditions or require formal treatment. Today, that understanding has shifted. We now recognize the significant mental health needs within this population, with an increased emphasis on self-determination, inclusion, and care in the least restrictive environment. And the scope of need is substantial. Mental health disorders are 3 to 4 times more common among individuals with DDs, and in 2020, over 8 million people in the United States had a developmental disability. About 1 in 3 individuals with a DD has a co-occurring mental health condition. So taken all together, this highlights that we have a system that is not adequately meeting the mental health needs of this population. To explore this issue, I conducted a literature review and 3 expert interviews. I met with Kelly Barnett from the Nysonger Center, Patricia Berger from Empowering Integrated Care Solutions, and Dr. Michelle Reynolds from the Life Course Nexus Training and Technical Assistance Center. As illustrated in the diagram located at the center of the presentation, 5 key themes and findings emerged across the literature and interviews. First, according to the research, psychotherapy can be effective for individuals with DDs when appropriately adapted. However, the evidence base remains mixed due to variability in study design and rigor. At this time, cognitive behavioral therapy has the most evidence, with reductions in challenging behaviors, anger, and mental and depressive symptoms, though findings remain more mixed for anxiety. Emerging evidence also supports train-the-trainer models and group-based interventions as cost-effective and feasible. Other approaches, such as EMDR, show early promise but require further research. Secondly, the importance of service fit is a central consideration. Mental health symptoms tend to present differently in individuals with DDs, meaning that traditional approaches must be intentionally adapted. Effective care requires a whole person perspective that considers comprehensive support for both the individual and their family and caregivers. Third, the literature review and interviews revealed best practices which emphasize individualized and flexible care and communication strategies, such as checking for understanding and using visual supports and active engagement techniques. Involving caregivers, teaching prerequisite skills, and supporting emotional regulation are also key components when working with individuals with DDs. Then, according to the expert interviews, they stress the need to shift the focus beyond symptom reduction to overall quality of life improvement. Frameworks like charting the life course promote person-centered holistic care. And finally, evidence-based models for severe mental illness, such as the Navigate program, may be applicable and adapted for this population. This program uses a manualized, structured approach and may already be developmentally appropriate as it accounts for cognitive and functional challenges similar to those experienced by individuals with DDs. Overall, the evidence base is growing, but it remains limited in rigor and continues to emphasize behavioral outcomes more than mental health and quality of life outcomes. Future research should strengthen methodology through more rigorous design, including randomization, control groups, and larger samples. It should also expand across levels of developmental disability and a wider range of mental health conditions while prioritizing outcomes beyond behavior. Service fit, best practices, and quality of life are opportunities for us to embrace in order to more appropriately and meaningfully serve this population. Importantly, effective approaches already exist, but they have yet to be adapted or they're not consistently implemented or integrated across systems. Of note, much of the progress has occurred within the developmental disability field than the mental health field. There is also a need to shift toward more preventative models of care to reduce outcomes such as hospitalization, incarceration, and institutional placement. In addition, emerging areas such as co-occurring substance use and involvement in the criminal justice system require further research in their own targeted interventions. Ultimately, with the profession's value of social justice and foundational skills, social workers are uniquely positioned to reduce barriers to care and help improve mental health care and outcomes for individuals with developmental disabilities. However, there are several ongoing challenges that contribute to this service gap in the mental health disparities. Systems remain rooted in a traditional medical model that does not fully account for co-occurring conditions. Fragmentation in DD and mental health services limits coordination and continuity of care, and there are significant gaps in training and education. In social work education, this suggests a need for a curriculum that includes content on disability-informed and intersectional clinical practice. And finally, stigma, bias, and diagnostic overshadowing remain persistent barriers, often leading to mental health symptoms being overlooked or misattributed to the disability itself. In closing, I would like to share a perspective from Patricia Berger of Empowering Integrative Care Solutions. She says, "We need to use a framework that is person-centered, trauma-informed, disability-informed, and grounded in a biopsychosocial understanding of the individual. In practice, this means not treating behavior, mental health symptoms, communication differences, trauma history, and environmental factors as separate issues, but instead understanding how they interact and influence one another. This resonates with the heart of social work and reflects the need for a truly integrated approach to care." Thank you. I would like to introduce my friend, Tara Thayer.
Hi everyone, my name is Tara Thayer. Thank you for being here. My capstone project is titled Creative Pathways to Healing, Art-Based Interventions in Eating Disorder Treatment. Eating disorders are complex mental health conditions that affect individuals socially, emotionally, and also run the risk of extreme physical health complications. Standard treatment is typically interdisciplinary, involving medical monitoring from a physician, nutritional counseling from a dietitian, as well as evidence-based psychotherapy such as cognitive behavioral therapy, dialectical behavior therapy, and for adolescents, family-based treatment. While these approaches are effective for many clients, relapse rates for EDs remain fairly high, indicating a need for innovative interventions that support longer-term recovery. My capstone project explores a critical question. What role do art-based interventions play in eating disorder treatment currently, and how might they support healing in ways that traditional talk-based therapies cannot? It is important to note that art therapy is a term exclusive to the practice of board-certified art therapists who undergo specific training in mental health and studio art concepts. While art therapy is its own separate clinical discipline, the reality is that art is often utilized as part of mental health treatment by individuals who may not have that specific title, such as social workers, counselors, behavior technicians, and even volunteer community artists who lead art-based activities without formal training in art therapy techniques in mental health settings. For the purpose of my capstone, I use the term art-based interventions to encompass all creative visual arts activities used in mental health treatment, whether administered by a certified art therapist or not. To better understand the role of these types of interventions in ED treatment, I conducted a literature review of existing empirical research and interviewed 5 mental health clinicians with expertise in either art therapy, art-based interventions, or eating disorder treatment, or both. I found that art-based interventions are already widely used in ED treatment settings, from inpatient to partial hospitalization to intensive outpatient settings. However, despite their prevalence, there is surprisingly limited high-quality empirical research evaluating whether or not they actually work in practice. Initial studies have found that art-based interventions are associated with better mental health outcomes, improved quality of life, and reductions in anxiety among eating disorder clients. Participation in art-based groups supports relational connection, enhances self-awareness, and offers opportunities for identity exploration to separate a client's sense of self from the eating disorder experience. On a neurological level, creativity helps to activate brain regions that have been damaged by ED-related malnutrition. My qualitative interviews also revealed several themes supporting the use of these types of interventions in eating disorder treatment. First, art provides a nonverbal pathway for emotional expression. Many individuals with eating disorders struggle to articulate their internal experiences, which may be why they turn to ED behaviors in the first place. Art offers a different form of communication, allowing clients to express complex emotions and internal conflicts that they struggle to put into words through the use of symbolism, metaphor, color, and play. Second, art-based interventions can increase cognitive flexibility. Eating disorders are often characterized by rigid black and white thinking patterns and a complicated relationship with control. So when you think of someone with anorexia nervosa, their temperament may present as more over-controlled, methodical, and perfectionistic, whereas individuals with bulimia may show up more as impulsive and struggling to control urges. Engaging in art activities, where the emphasis is on the process, not on creating the perfect product, can help individuals on all sides of the eating disorder spectrum to learn to tolerate ambiguity, practice adaptability, and learn skills in emotion regulation. Third, art can function as a safer embodied coping strategy. Rather than turning to disordered eating behaviors to manage distress, individuals can use creative expression as an outlet that engages the senses and reconnects them to themselves and their own bodies in a way that is sensory and kinesthetic. For people who are already turning to physical means to reduce their distress, such as through eating disorder behaviors, this sensory component can be really helpful. And finally, art making supports identity development and meaning making. Eating disorders often become deeply intertwined with a person's sense of self. Through art, individuals can begin to explore who they are outside of their eating disorder and challenge the idea that their self-worth is linked to their weight or how they appear. To organize all of these ideas, I developed a theory of change, which you can see here. I won't go into it, but these findings support the potential benefits of expanding access to art-based treatment approaches by equipping non-art therapists, like people like myself, social workers, counselors, psychologists, and others involved in the ED treatment spectrum, with the necessary knowledge and skills to integrate art into their clinical practice with eating disorder clients. However, it is important to acknowledge limitations. The current research base for this topic is limited, primarily looking at individual case studies with a few experimental trials that have small sample sizes that are not generalizable to the broader ED population. The effectiveness of art-based interventions may also depend heavily on how they are implemented, looking at things like the materials used in treatment, the directives given by the facilitator during an activity, and the sequence of activities over time in a progression. Currently, there is no evidence-based standardized protocol that researchers and clinicians can replicate. Additionally, because art-based interventions are so often just one component of a multifaceted treatment process, it is hard to isolate the effects of art-based interventions on their own outside of the other services that clients are receiving. In my poster, I make a number of recommendations for implementation, but one key point is that non-art therapists should not try to clinically interpret artwork. Leave it up to the client to tell you what it means to them. Additionally, careful selection of materials is paramount with art-based approaches, as messier mediums like chalk, paint, clay can be dysregulating for clients, especially those who present as more over-controlled and struggle when things don't go exactly right. And so these types of mediums may be more appropriate once clients are further along in the art-based intervention process. As the field moves forward, there is clear need for more rigorous research to better understand what it might look like to standardize art-based approaches and which types of creative activities are specifically most effective based on where clients are in their recovery process. Research should also evaluate whether effectiveness varies by specific ED diagnosis, whether bulimia, anorexia, or any of the other eating disorders on the spectrum. Ultimately, my findings suggest that art-based interventions may be an effective complementary approach to other aspects of the comprehensive ED treatment process that can enhance engagement and support fuller recovery. They offer a different entry point into healing, one that is embodied, expressive, and often deeply meaningful for identity development. Thank you, and I'd like to invite Ms. Emma Tropany to the stage.
Hi, everyone. My capstone explores clinician decision-making around sequential versus integrated treatment for veterans with co-occurring PTSD and substance use disorders in a VA residential setting. PTSD and substance use disorders, which I will refer to as SUD, frequently co-occur among veterans. Research with veterans who served in recent conflicts found that approximately 63% of veterans diagnosed with SUD also meet criteria for PTSD, highlighting a high degree of overlap. This comorbidity is clinically significant because it is associated with greater complexity in presentation, including higher rates of relapse, suicidality, homelessness, and functional impairment compared to either disorder alone. Historically, treatment systems relied on a sequential model, where substance use was treated first and trauma treatment was delayed until a veteran was considered stable or abstinent. This was based on concerns that trauma processing could increase risk of relapse. However, over the past 2 decades, the literature has shifted toward more integrated treatment models, which address PTSD and SUD concurrently. Research suggests these approaches are safe and effective, often producing comparable substance use outcomes and stronger PTSD symptom improvements. This led to my central question. How do clinicians decide whether veterans receive sequential or integrated PTSD and SUD treatment in residential care? Before moving into my methods, I want to briefly explain the conceptual model shown here in the middle. PTSD symptoms such as intrusive thoughts, hyperarousal, emotional distress often lead veterans to use substances as a coping strategy. While substance use may provide temporary relief, it frequently creates negative consequences, such as worsening mental health or impaired functioning. These consequences then intensify PTSD symptoms, creating a reinforcing cycle. Across both literature and the interviews I conducted, PTSD and SUD were consistently described as interconnected rather than 2 separate disorders. By treating both concurrently, integrated care can help interrupt that cycle. So to explore this question, I conducted a targeted literature review and a series of semi-structured expert interviews with 6 VA staff members working in residential treatment settings. Clinicians included psychologists, social workers, and counselors. We also, from the PTSD program and the serious mental illness dual diagnosis program. I also included 1 peer support specialist who had lived experience. So the findings of the literature review suggested 3 major conclusions. PTSD and SUD are highly interconnected. Integrated treatment is generally as effective or more effective than sequential care, especially for PTSD symptoms, and implementation often lags behind the evidence. Several key themes emerged from my interviews. First, PTSD and substance use were consistently viewed as interconnected, with substance use often described as a coping strategy. One clinician stated, "Substances are very good at calming down that part of the brain that gets triggered by trauma." While another noted, "Substance use feeds the avoidance cycle that is so common in PTSD." Second, clinicians generally preferred integrated treatment, though this was balanced with concerns about readiness. One clinician explained, "Folks need care that explores how PTSD and SUD go together to break that cycle." However, integrated care did not always mean immediate trauma processing. As one provider noted, people in groups are getting PTSD treatment. They're at stage 1, often involving coping skills, psychoeducation, before formal trauma processing. Third, readiness was the primary decision-making factor, but it was defined inconsistently. It included emotional regulation, motivation, insight, and psychiatric stability. Clinicians emphasized willingness to engage, with one stating they need to say it themselves. They need to be intrinsically motivated. Fourth, structural factors within the VA influenced access to trauma care. PTSD treatment was often described as more gated, following stabilization in SUD or serious mental illness programs. One SMI clinician noted, "We treat them until they look good enough to get into PTSD." And a PTSD clinician highlighted capacity constraints, stating, "We're expected to do a lot all at once," referencing the intensive nature and inherent small caseloads required for trauma processing. Finally, peer support was described as an important engagement mechanism, reducing stigma and building trust. The peer support specialist explained to me they see themselves in me. Overall, findings suggest a gap between empirical support for integrated PTSD and SUD treatment and real-world implementation in the VA setting. Integrated treatment appeared to exist on a continuum rather than as a single model, ranging from stage 1 trauma groups and coping skills to full trauma processing protocols delivered alongside substance use treatment. Access often depended on readiness and stage of recovery. Differences in how readiness was defined and assessed may contribute to inconsistent access to care, suggesting that greater standardization could improve equity and transparency. Finally, program limitations such as referral structures, staffing, treatment capacity, all shaped veteran treatment options. Future research could examine how readiness is assessed and how it influences access to care, as well as how screening tools and program requirements affect equitable access to trauma-focused treatment. In conclusion, this study highlights how clinician decision-making shapes treatment pathways for veterans with co-occurring PTSD and substance use disorders, and emphasizes the importance of aligning evidence-based integrated models with real-world implementation. Ultimately, access to trauma-focused care should not depend on appearing well enough, particularly when trauma may be central to ongoing distress or substance use. With that, I want to thank our faculty, staff, and peers at the Mandel School, our mentors and Dr. Hussey for their support and guidance, and the Mandel Foundation for their generous support. Thank you to those of you who attended remotely. Now we will transition to the poster session.